Thank you, Dr. Mukherjee. Thank you so much. And thank you, organizing committee, for inviting me here. Having spent my childhood here, I am very nostalgic about the city of joy. So what is quintuple therapy? Sir spoke about the four pillars of therapy. Now, which is the fifth pillar? Fifth pillar is the quintuple part of the therapy. We all know about this. Four pillars are ARNI, SGLT2 inhibitor, beta blockers, and MRA. All these four pillars are very well established part of the guideline-directed medical therapy. The fifth pillar is vericiguat, which is used now for worsening of heart failure with reduced ejection fraction. So how do we define worsening of heart failure? Sir spoke about it. Even after giving all four therapies, how do we define worsening heart failure? And this is the definition from European Society of Cardiology and Heart Failure Association. This is the consensus definition of worsening of heart failure. It is a worsening of signs and symptoms of heart failure, which requires intensification of treatment, particularly intensification of diuretic therapy, which can be either in the hospital or in the emergency department or even in the ambulatory setting. Patient has come to your OPD and you increase the dose of diuretic therapy. It can be intravenous therapy, it can be oral therapy. So whenever you have to increase the dose of increase the dose of diuretic therapy for worsening signs and symptoms, then these are defined as worsening of heart failure. It excludes new onset heart failure. It includes patients who are not compliant, or who includes the patient who have concomitant factors causing this thing. So whenever you have to increase the dose of diuretic, whether it is intravenous diuretic, whether it is oral diuretic, whether it is in your setting, whether it is in your hospital, then these are defined as worsening of heart failure. And why we are so worried about worsening of heart failure? Now, residual risk is always there with worsening heart failure, and the risk is of cardiovascular death among patients who are already on quadruple therapy. And this data has come from DAPA heart failure studies. See, with paradigm heart failure study, we know that the patient experiencing a primary outcome of event, that is either heart failure hospitalization or cardiovascular death, it is reduced by 19.9%. But if you, with three drugs, ARNI, beta blocker, and MRS, but when you add dapagliflozin, we have data from this DAPA heart failure trial. So when a patient is on four therapies, all the four pillars of therapy, it reduces from 19.9% to 14.3%. That means 1 out of every 7 patients experience a primary outcome event despite confirmed use of quadruple therapy. So even if you are on the four pillars of therapy, that is ARNI, beta blocker, MRS, and SGLT2 inhibitor, you still have 1 out of 7 patients ending up with worsening of heart failure. So how do we treat them? And why we should treat them? And how do we define worsening of heart failure? Worsening of heart failure events are associated with increased risk of mortality. They die, increased risk of mortality, regardless of care location, whether it is heart failure hospitalization, whether it is outpatient department, whether it is in your clinic. Not even heart failure, patient has gone to emergency department, or patient has come to your clinic and you have increased the dose of heart. And compared to patient who had no worsening of heart failure, this violet bar, you see this. Even if you have increased the dose of diuretic in outpatient department, this patient have an increased chance of all-cause mortality, significantly increased chance. Look at the height of this bar, look at the height of this bar. These are heart failure hospitalization, this is emergency department visit. So whether patient has been admitted with worsening of signs and symptoms, whether patient is reported to emergency department in the middle of night with breathing difficulty, or patient has come to your clinic and you have increased the dose of diuretic, then still that patient has a very high chance of all-cause mortality. So this patient needs special attention. So what is meant by worsening of heart failure without hospitalization? In hospital, patient has come, we all know. This patient will be given intravenous diuretic, will be treated well. But even without going to hospital, if a patient has come to outpatient department and has required intravenous diuretic, or patient has come to your clinic and you have increased the dose of diuretic, then it is also considered as a worsening of heart failure. And emergency department visit and discharge without hospitalization. This is a very common entity in India. Patient comes to emergency department with breathing difficulty in the middle of night. The emergency doctor gives intravenous diuretic, patient improves and he refuses to get admitted. So all these patients are labeled as worsening of heart failure. And it is not only the hospitalization, but it is oral enhancement of diuretic therapy in your clinic is also labeled as a intensification of treatment, and they have a worse mortality. So not just heart failure hospitalization, but also the intensification of oral, I again repeat, intensification of oral diuretic therapy means increased risk of heart failure, mortality and readmission rates. And look at this. At the end of 1 year, if your diuretic intensification is, and look at this blue line, the hazard ratio is 1.49. So these patients have a higher chance of dying, even if you have increased the dose of diuretic in your clinic. So we have a drug called vericiguat. These 4 pillars of therapy, we know it. So now there is a 5th drug called vericiguat. Vericiguat has a different way of action. It is a different mechanism of action. Vericiguat targets a well-recognized pathway, but it's tailored specifically for heart failure with reduced ejection. So far, we have no data for heart failure with preserved ejection fraction in this setting. But in heart failure with reduced ejection fraction, if a patient has a worsening of heart failure, and if you give a vericiguat, it works through this nitric oxide channel by acting on cyclic guanylate cyclase enzyme, and that increases the level of cyclic guanosine monophosphate, and this improves the heart pumping, it improves the heart mechanisms. So there was a trial called Victoria trial, which specifically designed to study these sort of patients. They included patients who had a chronic heart failure. They were in class 2, 3 and 4. LVF was less than 45%, and they were all on proper standard of care. On top of that, you are giving vericiguat. So they were all on standard of care, and they were given vericiguat. And most of these patients had history of heart failure hospitalization. They also had elevated natriuretic peptides, and these patients were randomized to either inpatient vericiguat therapy or in outpatient vericiguat therapy. And study drug was initiated in about 11% of patients who were admitted to hospital. There was no such studies where they included the indoor patients. And when you give vericiguat on top of standard of care and compare it with placebo, there is a hazard ratio is 0.90. That is means 10% reduction in the primary outcome of first heart failure hospitalization, cardiovascular death. Now this number looks very insignificant, 10%, but look at this number. Absolute risk reduction was 4.2 events per 100 patient years. And all you need to do is to treat 24 patients for mean of 10.8 months, and then you will be able to prevent 1 episode of either death or heart failure hospitalization. Now, why this number reduction seems so less, 10% reduction? Look at this paradigm heart failure trial. The NT-proBNP was 1608. Here, look at this. NT-proBNP was 2816. So they included more of a serious patients. Number of patients in class 3 and class 4 was 25% in paradigm heart failure trial. Here it is 41% of patients. Most of these patients were hospitalized. They were sick patients. So heart failure hospitalization patient within the preceding 6 months was only 31% in paradigm heart failure trial, while here it was 84%. So 84% of these patients were in hospital because of worsening heart failure in the preceding 6 months. They had a high NT-proBNP and they were in class 3 and 4. And look at the primary endpoint. What was the mortality rate in placebo arm? That was 13.2 events in 100 patients. Here it was 37.8 events per 100 patients here. So they were really sick patients. In placebo arm, they had a chance of dying was 37.8%. So even if you gave a slightest benefit, you have done a great benefit. They were very safe drugs. Incidence of adverse events or serious adverse events were very minimal. They were like placebo. Their symptomatic hypotension was slightly high. Syncope was not much high. And most of these patients were able to achieve their full dose of 10 milligram within 12 months. A good number of these patients had diabetes and renal impairment underlying. So they were sicker patients. And look at the advantage. When you take paradigm heart failure trial, which has become a landmark trial, the absolute risk reduction was 2.7. DAPA heart failure has shown absolute risk reduction of 4. But look at this. Vericiguat has shown absolute risk reduction of 4.2. So primarily a good drug on top of standard of care of therapy. There are 3 main concerns when we start this sort of a new drug. We are always worried about blood pressure is too low or kidney function is deteriorating or patient has got hyperkalemia. So does it work? In older people, patient above the age of 75 or below the age of 75, the blood pressure drop is not significant. Patient who had a BP of more than 110 or patient who had a BP of less than 110, reduction in BP was not much. So don't worry about the drop in blood pressure. Similarly, use of ARNI or no use of ARNI, drop in blood pressure was not very significant. So it's safe drug. It does not cause too much of blood pressure reduction. What about kidney parameters? Slightly high incidence of worsening of kidney functions, but not statistically significant. What about hyperkalemia? It does not increase potassium value. In fact, it slightly decreases potassium value. So do not worry about that. there are three main scenarios for starting Vericiguat. One is contraindication or intolerance of one or more pillars of the therapy. There are 4 pillars of guideline-directed medical therapy. Now, this patient has come to you with creatinine of 5. Will you be able to give ARNI? Will you be able to give MRS? He has come to you with heart rate of 60. Will you be able to give beta blocker or no? So, whenever there is a contraindication or intolerance to one of the 4 pillars of therapy, then you can use Vericiguat. In combination with optimization of 4 pillars. So, you have given small doses of all the 4 pillars of therapy or optimizing therapy and patient has worsened, that time you can add Vericiguat. And after optimization of 4 pillars, there will be a small number of patients where you have given all 4 therapies, patient is taking it in the whatever dose he is tolerating and still he has shown a worsening. He has come to you in your clinic with pedal edema, breathing difficulty, inability to lie down and you have increased the dose of diuretic. That is the time you should add Vericiguat also. Do not use Vericiguat after multiple episodes of worsening of heart failure, multiple episodes of heart failure hospitalization. It should be used at the first worsening of heart failure. And what are the practical things? It should be given to all patients excepting patients who are pregnant. It has not been tested in pregnancy. It should be given, start with 2.5 milligram. At the end of 2 weeks, increase the dose to 5 milligram. And end of another 2 weeks, you can increase it to 10 milligram. 10 milligram is the maximum permitted dose. And it should be given to a patient who have been having systolic BP of more than 100 and he is off any intravenous diuretic therapy. And you can give it to advanced renal failure also. So long as eGFR is more than 15, you can safely prescribe Vericiguat without any worry. So which are the 3 clinical scenarios where you can use Vericiguat? I think one is clinical scenario 1. A patient who has experienced a decompensation event under optimal background therapy. So you have given all 4 pillars of therapy and most of the cardiologists do give it to the maximum tolerated dose of therapy and still patient has shown worsening of heart failure, there you can give it. The second clinical scenario is a patient who experienced a decompensation event under suboptimal background therapy, which is very common in our setting, and patient is not on the full dose of MRS or not on full dose of ARNI and he has developed a worsening of heart failure. He is reported to the hospital with breathing difficulty. There also you can give. Sometimes we cannot give all these 4 pillars of therapy because of contraindication like hyperkalemia or worsening renal failure. You cannot, patient has developed a significant side effect, say with SGLT2 inhibitor, he has developed a genitourinary mycotic infection, you cannot give it. There also you can give it. Low systolic blood pressure, low eGFR and high serum potassiums are not a contraindication. If your patient has a high potassium, you cannot give MRS. If patient has significant kidney problem, you cannot give ARNIs. There you can give Vericiguat safely. Third clinical scenario is a patient who has experienced a decompensation event during suboptimal therapy. You have not built up the dose of all the 4 therapy to the maximum and patient suffers a worsening of heart failure. There you continue to build up the dose of 4 pillars of therapy. At the same time, you can give him Vericiguat as additional therapy. So to conclude, friends, it could be the fifth pillar of therapy on top of the 4 standard of care therapy, particularly in worsening of heart failure. Now question is, it works through a different mechanism. Can we not give it to all heart failure patients? No, we still don't have the data. Victor studies is being done now. The data will come by the end of this year, whether we can give it to all heart failure patients to prevent worsening of heart failure. But as of now, we do not have data. It is not to be used as a last resort. You should use it as a first worsening of heart failure therapy. And first worsening is whenever patient needs escalation of either oral or intravenous diuretic therapy. That is the time you should add Vericiguat on top of the standard of care. It should not be used as a last resort. It can be used even if eGFR is very low. Now this is a big problem. They will have a cardiorenal syndrome. Most of our patients do have it. They have a ARNI, they are on MRS, they are on diuretics and they have a worsening of renal function. But so long as eGFR is more than 15, you can safely use Vericiguat. It is quite safe in kidney failure patients. Absolute risk reduction is quite significant, that is 4.2%, and there is no issue of major hypertension, hyperkalemia. You can safely use it. Thank you so much. If you have any questions, I'll be very happy to answer your questions.
Dr. Desai, very good presentations of a new drug to add on a 5th pillar. Now, question is that as a clinician, can we predict which group of patient will develop worsening heart failure? Either depends on reversible factors or irreversible factors. Adding a drug, it will help, but unless we identify and predict the cases beforehand and pick up the risk factors, we may not be able to attain those factors as well. One day we'll have a sixth pillar, seventh pillar, eighth pillar. I think it's better to identify the risk factors which will help us as a clinician.
As you all know, sir, heart failure with reduced ejection fraction is a progressive disease. Eventually, it keeps on progressing. It will be a downhill journey only. Your question is patients who are not compliant, patients who are not taking your advice about salt restriction or water restriction strictly. They are not taking the medicine which you have prescribed, like ARNI or beta blocker. They are likely to worsen. Those who have comorbidities like iron deficiency, anemia, COPDs, they will show more worsening with this. So, this drug has to be given to a patient when you are sure that he is taking all 4 pillars of therapy, he is compliant, and he has no associated reason for worsening of heart failure. The most common is missing the drugs. So those things has to be ruled out. Patient who is already on 4 pillars of therapy in whatever dose they tolerate and still is compliant and still he develops worsening, then this drug is important.
Thank you, Professor Desai, for the crystal clear indications and contraindications for the new molecule. If there are any questions from the audience.
In fact, there is hardly any contraindication excepting pregnancy or
Except in
EGFR
pregnancy.
below 15.
Is there any gender difference in response to Vesigard?
Pardon, sir?
Any gender difference in response to these newer drugs?
No, I don't think so.
Acha, during Victoria trial, the patients were also on SGLT2 inhibitors?
Only a small number. This trial was started before SGLT2 came into the approval list. So most of these patients, your question is very valid question, sir. Only a small number of patients were on SGLT2 inhibitor. So I fully agree with you. Once we patients are on SGLT2 inhibitor, whether this benefit will be there or not, that is that question.
Or there are concerns of combining SGLT2 with Verisogard.
No, there is no contraindication. You can combine it. I mean, you can combine these two. But most of the patients who were included in Verisogard trial were not on SGLT2 inhibitor. Because when this trial was started, SGLT2 was not the standard of care.
I have a small query. We come across quite a lot of patients with 4 foundational therapy coming up in the ICU with ADHF. Now, should we wait for some time to take the patients out of the cloud, or we start Verisogard at the first
Two criteria
touch?
has to be fulfilled, sir. Systolic BP should be more than 100 and patient should be off IV diuretic for 24 hours. Then you should start it.
Okay. Any other question?
At what level of GFR, low GFR, this drug can be used?
Up to 15 GFR.
15.
So I have many CKD patients where I can't give ARNI, I can't give MRS, and their BPs are also borderline, so I can't give beta blockers. I've given only Verisogard.
Can be given on patient on dialysis?
If eGFR is less than 15, you cannot give it, sir. As of now, you cannot give. Nobody has studied it in dialysis. But I see no harm. I mean, it doesn't affect kidney in any way. So it should be given, in my opinion.
In your slide, you have shown the reduction in BP is not significant.
Not significant.
Then why hypotension is the contraindications to start the therapy?
No, I mean, there is
SGLT inhibitors can be given in hypotension also. ARNI can be
there
given.
is no significant reduction. In placebo group, it was 7%. In Verisogard, it was 9%. So 2 extra percent had some drop in the blood pressure.
Because of the trials have excluded hypotensive patients. That is why.
No, trials have included patients who had BP of 100. They did not include patients who had BP
Below
was less than
100.
100.
So we don't have data for
We don't have data.
BP
But
below 100.
whatever trial has shown that it causes some 2-3 millimeter drop in the blood pressure, not very significant.
Are there any other trials where after the 4th pillar, this has brought up a certain percentage of reduction in adverse events? Or with all 4 pillars already in use, does this Verisogard reduce further by any percentage, any data?
No, that was what Sir's question was. That was a very valid question. Most of these patients were not on SGLT2 inhibitor when this trial was started.
And another point I remember my childhood days, he is having a systolic blood pressure.
Please give chance to other people.
He is
Last
having a
question.
systolic blood pressure 80 or 90, can't give Lasix. If we give Lasix and decongest him, cardiac output will increase, his mean arterial pressure will increase. So maybe with Verisogard or
Yes.
SGLT2. So
It's quite a safe drug. It doesn't cause too much of drop in blood pressure.
Dr. Desai,
Yes, sir.
Last question.
last question.
Yeah.
as a young consultant physician, I see a lot of heart failure patients, more so the HFrEF patients. Agreed. Heart failure therapy should be always aggressive right from the very outset. Whenever first instance of worsening of heart failure happens at the fifth drug. Since vericiguat acts in the cGMP, that is cyclic guanosine monophosphate pathway, is there any contraindication in those patients or in those subset of patients who have some sort of hepatic impairment or who have some sort of deranged liver function?
No, I don't think, unless there is advanced renal failure or advanced hepatic failure, then you cannot give it. But even moderate
No,
renal
how the- no,
hepatic
no.
failure, you can give it.
Now, how the drug is excreted? Is it excreted through the kidneys or is it excreted through the liver?
It is not excreted through the kidney, sir.
So then through the liver.
Probably through the liver.
So there is no contraindication if
No,
the
no.
patient has any
No, no.
deranged liver function.
Unless liver is very acutely, severely damaged. Otherwise, you can give it. Mild to moderate hepatic failure is not a contraindication. And what you ask about contraindication, only it should not be combined with nitrate and PD inhibitors. You don't
Because of
combine with
angio-
sildenafil.
Because of angioedema or something like that?
No, not angio. It will cause significant drop in blood pressure.
Okay, no.
So it should not be
Thank
given
you.
along with
Thank
nitrates
you.
or with PD
Thank you,
inhibitors.
thank you.
Thank you. Thank you, Dr. Desai.
Thank you, sir. Thank you so much.
Thank you. Session is closed.